Hi everyone, and welcome to our module on pneumonia. Pneumonia is infection of the lungs, and there are three classic patterns of pneumonia infections that you need to know, especially for step one. The first type is lobar pneumonia, the second one is bronchopneumonia, and the third type is interstitial pneumonia, which is sometimes called atypical. So first we'll talk about lobar pneumonia, and like the name implies, this is pneumonia that involves one or more lobes of the lung. This is the classic form of pneumonia, and it's classically caused by the bacteria Strep pneumoniae. Bacteria are acquired in the nasopharynx and then they become aerosolized and travel down into the alveoli. They enter the alveolar type 2 cells and then they multiply inside the alveoli. Eventually they invade the alveolar epithelium and they can pass from one alveolus to the next through structures called the pores of Kohn. Eventually you develop inflammation and consolidation of the lobes, and it can progress from one lobe to another and ultimately involve the entire lung. So this picture on the left here is a chest x-ray of a patient with a right upper lobe pneumonia, and you can see how there are clearly demarcated areas where you pass from white tissue to black lung, and that's because those are the edges of the lung field. And over here on the right side of the screen is a drawing of the different lung fields, just showing you how the right upper lung is what's involved in this patient on the chest x-ray on the left. There are four classic stages that lobar pneumonia progresses through, and you need to know these especially for step one of your boards. The first stage is called congestion. This happens in the first 24 hours. Capillaries in the alveoli dilate in response to infection, and an exudate of mostly bacteria develops. The second stage is called red hepatization, and hepatization means the lung begins to look like the liver. It comes from the same root as the word hepatic, and it gets its name because autopsies of people who died in the first 2 to 3 days of infection would show lobes of the lung that looked like the liver, hence the name hepatization. And it's called red hepatization because the color of the lung in this stage is red. This happens about 2 to 3 days after infection, and exudates of red blood cells and neutrophils and fibrin form, and this is what give the lung that red color. It's a fresh exudate. It's got lots of intact red cells and white blood cells. The pneumococci are still alive, and as I said before, the lobes will look red in this stage. In the third stage, the lobes of the lung that are infected still look like the liver, so these are hepatization stages. But the third stage is called gray hepatization because now the lungs look gray and firm. They're very pale. This happens 4 to 6 days after infection. There's an exudate of neutrophils and fibrin inside the lungs. The red blood cells have started to die and disintegrate, and the pneumococci are also dying and disintegrating in this stage. So you can just remember that the gray is like a sad color, like at a funeral, and that's because everything is dying. The red blood cells are disintegrating, the pneumococci are dying. Finally, you reach the fourth stage called resolution, and this is where the lung returns to normal. And the lung has a tremendous regenerative capacity. It often goes back to normal after pneumonia with very little scarring. There are enzymes which will digest the exudate, and then this is very high yield to know. The type 2 pneumocytes will regenerate the lung. These are the cells that can regenerate lung tissue after pneumonia. So the second classic form of pneumonia is called bronchopneumonia, and the difference between lobar and bronchopneumonia is that in bronchopneumonia you see patchy infiltrate instead of that solid white infiltrate, and it involves multiple lobes. This is a picture of bronchopneumonia in this x-ray down here on the left, and you can see that there are splotches of white throughout both lung fields. In bronchopneumonia, there's primary involvement of the airways and the surrounding interstitium, and the classic bacteria to cause bronchopneumonia is Staph aureus. And this is just a drawing over here on the right of these little splotches that occur in bronchopneumonia. The third type of pneumonia is called interstitial pneumonia, and this is where there's an inflammatory infiltrate of the alveolar walls only. And you get a picture like what I've shown in this chest x-ray down here. There's increased whiteness in both lung fields, and it's kind of streaky. You can see little white lines streaking through the lung fields, and that's what you see in interstitial pneumonia. These types of pneumonia are more benign. They follow an indolent course. Patients generally aren't as sick. There are some viruses that cause this type of pneumonia and also certain atypical bacteria. These are bacteria like Legionella, Mycoplasma, and Chlamydia. You'll sometimes hear clinicians say that a patient has an atypical pneumonia, and what they mean is that the patient has an interstitial pneumonia caused by one of these bacteria here. And these bacteria are often called atypical bacteria because they're not Strep pneumoniae. Strep pneumoniae is a typical pneumonia bacteria. These are atypical bacteria, and they generally cause that milder interstitial form of pneumonia. These are Legionella and Mycoplasma and Chlamydia. As I said before, it's usually milder than strep. Respiratory distress is rare. You will see interstitial infiltrates on chest x-ray, and this is a picture of it here again. And sometimes people call these a walking pneumonia. And by walking pneumonia, they mean that the patient is not sick enough to be bedridden or hospitalized and they can walk around with the pneumonia. Some people also like to say that in these interstitial pneumonias, the chest x-ray looks worse than the patient. And what they mean is that the patient has a mild cough, but you get an x-ray and you see lots of these streaky white interstitial infiltrates, and it's surprising to you because you don't think the patient looks that sick. And that's just a testament to the fact that this is a milder form of pneumonia. So let's talk about the bacteria that cause pneumonia. And first we'll talk about children because they have some special causes. So neonates up to 4 weeks old have infections caused by Group E strep and E. coli. And these are the same bugs that can cause meningitis in newborns. And it's easy to remember that because they come from the mother and they pass to the baby when the baby's born. So these bacteria are found in the vaginal canal and they infect the baby during birth. Children that are a little bit older, 4 weeks old up to 18 years of age, get pneumonia from RSV very commonly. This is a type of virus that we'll talk about later. They get some of these atypical pneumonias like mycoplasma and chlamydia, and then they also sometimes get strep pneumoniae. In adults, strep pneumoniae is the most common cause of bacterial pneumonia. Now, in reality, we don't know the most common cause because we usually don't isolate the bug. So we treat thousands of people every year for pneumonia without isolating the bacteria, but we believe this is the most common cause based on older data. Other bacteria that can cause pneumonia in adults include Haemophilus influenza, mycoplasma, as I mentioned before, chlamydia, and Legionella. These are all those atypical bacteria. Other causes of pneumonia are gram-negative rods like Klebsiella and E. coli and Pseudomonas. These are uncommon causes of pneumonia unless the patient is very, very ill, and they often happen in sick, hospitalized patients. Staph aureus is an uncommon cause of pneumonia, but it does occur after someone's had the flu. So the flu, as you may know, is caused by a virus. But when people are recovering from that virus, they can get a subsequent bacterial infection, and Staph aureus likes to do this, although so does strep pneumoniae. Anaerobes can cause infection, especially when someone aspirates. For example, if they vomit and aspirate those lung contents, they can get an anaerobic pneumonia or a lung abscess. We'll talk more about this later. And finally, some viruses cause pneumonia like influenza and RSV in children. The signs and symptoms of pneumonia include a high fever from the inflammation, cough, and sputum production from the lung infection. The white blood count is usually elevated, and patients can get pleuritic chest pain. That's chest pain when you inhale. You stretch the pleura, and if the pleura are involved in the inflammation, it will hurt when you do that. Usually the diagnosis of pneumonia is made just by history and physical exams, sometimes with a chest x-ray. Very rarely we have to also do a CT scan. There are some other tests that are sometimes done in special circumstances. You can send a sputum culture if you really want to know what the bug is. And then there's a test called a bronchoalveolar lavage. This is when a pulmonologist inserts a camera into the lungs and goes way down into the bronchi and then lavages it with a liquid solution and collects some of the cells. And then you can send it to the lab and culture it and see what bacteria grows. So in medical school, you learn a lot about the different bugs that cause pneumonia, but in clinical practice, you usually don't know what the bug is, and you're going to select a treatment for your patient based on the most likely bugs given the clinical setting. So if you want to do this, you have to know the different bugs that occur in different clinical settings. So patients who acquire pneumonia in the community, who come into your office or maybe the emergency room with a case of pneumonia, usually have pneumonia from strep pneumoniae, H. flu, or Staph aureus. Sometimes it's from the atypical bugs like Mycoplasma and Chlamydia and Legionella. Patients who acquire pneumonia when they're in the hospital for another reason often have very bad bugs. These are often gram-negative infections with Pseudomonas or Klebsiella or E. coli. This is sometimes called a hospital-acquired pneumonia. If they acquire the pneumonia when they're on the ventilator, it's called a ventilator-associated pneumonia. And if they acquire the pneumonia when they're in a nursing home, for example, it's called a healthcare-associated pneumonia. And all these nosocomial infections are generally more severe and harder to treat than the community-acquired cases. So now let's talk about how you treat pneumonia by selecting antibiotics. So if someone gets pneumonia in the community and they have no comorbidities like diabetes or kidney disease or heart disease, and they haven't been on antibiotics recently, and there's low resistance to antibiotics in the community, we call that an uncomplicated community-acquired pneumonia. In these cases, you can use an antibiotic like azithromycin or clarithromycin or sometimes doxycycline. Usually patients are given a 3 to 5 day course, or they take the drug until they're afebrile for 2 or 3 days and they're stable. When certain clinical features are present, we call it a complicated community-acquired pneumonia. And these features include things like COPD, renal failure, diabetes, heart failure, alcoholism, or if the patient's been on antibiotics recently. So if you have a patient with a complicated community-acquired pneumonia, The recommended drugs are a fluoroquinolone like levofloxacin or amoxicillin plus azithromycin, and there are other options that you can look up when you're treating these patients. In actual practice, a lot of doctors just presume it's a complicated case, and that's why a lot of people like levofloxacin. Some people call it vitamin L, because you can give it to anyone who's got pneumonia and you don't have to worry about whether it's complicated or uncomplicated. The problem with this approach is in a lot of places in the country, resistance to levofloxacin is starting to develop, but it's very popular because it treats a lot of forms of pneumonia and it's generally well tolerated. If patients get pneumonia in the hospital or the nursing home, then, as I said before, it's called a nosocomial pneumonia. And these are very difficult pneumonias to treat because the bacteria that cause these have lots of resistance to antibiotics. These infections often involve gram-negative rods like E. coli and Klebsiella and Enterobacter, especially Pseudomonas and Acinetobacter. Staph aureus also sometimes causes these infections, including methicillin-resistant Staph aureus. So you often treat these patients very broadly with drugs that cover Pseudomonas and MRSA. Sometimes you have to use multi-drug combinations. Some of the antibiotics that are sometimes used are cefepime or ceftazidime, sometimes imipenem or meropenem, and sometimes piperacillin and tazobactam, which is called Zosyn. And these drugs all have anti-pseudomonal activity in a very broad spectrum, and that's why they're used for nosocomial pneumonias. Patients with pneumonia can develop several important complications. They can develop sepsis and even septic shock. They can develop respiratory failure, and when you rotate through the intensive care unit, you'll see many patients with pneumonia who are on a mechanical ventilator to help them get over their bout of pneumonia. Pneumonia can lead to a lung abscess. It can lead to pleural effusions, and those effusions can sometimes get infected. That's called an empyema. And it can also lead to something called the acute respiratory distress syndrome. The acute respiratory distress syndrome is called ARDS for short by most people, and this is a lung syndrome that's triggered by various lung injuries, including pneumonia, but there are also others. What happens in ARDS is some type of injury leads to the release of pro-inflammatory cytokines like TNF and interleukins. These cytokines start to draw neutrophils into the lungs, and the neutrophils release toxic mediators like proteases and reactive oxygen species. This results in capillary endothelial damage and also damage to the alveolar endothelium. Protein then spills from the vascular space, and whenever you lose protein, it takes fluid with it. So the result is that fluid pours into the interstitium. This is the same problem as pulmonary edema in heart failure, but in heart failure, you have high pressures driving fluid into the interstitium. In ARDS, you have fluid in the interstitium because of leaky vasculature from inflammation. So the triggers for ARDS are sepsis most commonly, but also infections like pneumonia. Patients who aspirate can develop ARDS. Trauma patients get ARDS. Happens in acute pancreatitis and sometimes in transfusion-related acute lung injury, which is called TRALI. And the chest X-ray in ARDS is often described as a whiteout. This is an example of one here. And one thing you should know is that pulmonary edema from heart failure can also look like this. But the difference is, in ARDS, the PCP wedge is normal. If you were to put a Swan-Ganz catheter into this patient whose chest X-ray is shown here, you would see that the pulmonary capillary wedge pressure is something like 12 or 10. It's a normal value. In order to get this chest X-ray from heart failure, you would need a wedge pressure of 25 or 30, something very high. And in fact, normal wedge pressure is one of the diagnostic criteria for ARDS in clinical trials because they want to make sure they're not accidentally enrolling people into trials who have heart failure. There really is no good treatment for ARDS except supporting people with the ventilator and allowing time to pass and hoping that it resolves. It has been shown that if you use a low tidal volume on the ventilator, this helps. So when patients are ventilated by a machine, you can set the tidal volume, which is the volume of air that each breath will hold, and you can also set the respiratory rate. It turns out that in ARDS, these patients do better if you set the tidal volume very low, and then you can set the respiratory rate higher to compensate. This causes less injury to the lungs and helps the patients be more likely to get over the ARDS. You also support them generally with fluids and nutrition. And a big problem in ARDS is that patients can go on to develop a ventilator-acquired pneumonia, and this is often life-threatening. So what I'm going to do for the rest of this module is talk about some specific pneumonia bugs that have unique features you need to be aware of. And the first bug I'm going to discuss is Legionella. So Legionella was first identified at an American Legion convention where there was an outbreak of pneumonia, and that's how it gets its name, Legionella. The infection is caused by inhaling aerosolized bacteria in water vapor. At this convention, there were bacteria in the water vapor in the air conditioning system, and that's how people got sick. So it's not that the bacteria gets airborne, it's that it gets aerosolized. And if you know the history of how this bug got its name, it helps you to remember that it causes outbreaks at hotels with contaminated water. And in fact, that's a classic way for it to be described in a board question. It can also cause nosocomial pneumonia in nursing homes if it gets into the water system there. So initially, Legionella causes a mild pneumonia. Remember that it's one of the atypical pneumonia causes, and those atypical or interstitial pneumonias are usually milder. So these patients may have a fever, but they'll have mild, slightly productive cough. It can progress to a severe pneumonia in some patients, especially elderly patients or patients with comorbidities. And two special features of Legionella pneumonia that you should know about are the GI symptoms and the low sodium level. So patients with Legionella often have concomitant GI symptoms like watery diarrhea, nausea, vomiting, or abdominal pain, and that makes this a unique bug in terms of pneumonia causes. In addition, patients with Legionella classically have hyponatremia. They can develop a sodium level that's less than 130. Now, in reality, any pneumonia can cause hyponatremia, and hyponatremia is very common in the hospital in patients with pneumonia, but it's more common in Legionella, and if it comes up on a board question, it's most likely going to be from Legionella. Legionella has special culture requirements. It does not gram stain well. One of the media that's often used is called buffered charcoal yeast extract. This has iron and cysteine added, which helps the Legionella to grow. It's also supplemented with a couple of things, antibiotics and silver dyes, and these prevent overgrowth of competing organisms, and the dye also gives a distinctive color to Legionella. Now, because it's so hard to culture, often a culture is not done, and there's a urinary test. It's called a urinary antigen for Legionella. And this lets you know in a few minutes if the patient has been exposed to Legionella. It doesn't test for all Legionella subtypes, however, so just because the test is negative doesn't necessarily mean the patient can't have a Legionella pneumonia. So the classic case is a patient with a mild cough and watery diarrhea. The patient may have confusion from the low sodium level, and there'll be negative bacteria on gram stain because, as I said before, Legionella doesn't gram stain well. You can diagnose it with the urinary antigen test, and then the antibiotics that are usually used are fluoroquinolone or azithromycin because both of these antibiotics cover atypical bacteria. Besides Legionella pneumonia, there's another infection Legionella can cause, and that's called Pontiac fever. And this gets its name because after they discovered Legionella at the American Legion Convention, there was another outbreak caused by Legionella in Pontiac, Michigan. This is a milder form of Legionella infection. Patients will have fever and malaise, chills and fatigue, typical infectious symptoms, and usually a headache. But importantly, they won't have respiratory complaints, and the chest radiograph will usually be normal. Next bacteria we'll discuss is Mycoplasma pneumonia. This is another atypical pneumonia, and you can't see Mycoplasma on gram stain because it has no cell wall. This classically causes outbreaks in young adults, so you'll see description of outbreaks in a college dorm, for example, or in a military base among recruits. Like with some of the other interstitial pneumonias, the chest x-ray can look worse than the symptoms, so the patient can have mild symptoms, but a chest x-ray showing lots of interstitial inflammation. And two special things to know about Mycoplasma pneumonia are that it can cause anemia and skin disease. So the anemia is an autoimmune hemolytic anemia. There's an IgM antibody produced from infection that attacks red blood cells. And this is an example of a cold hemolytic anemia. There are both warm and cold anemias, and this is a cold one. And then in addition, Mycoplasma can cause Stevens-Johnson syndrome, which is a life-threatening skin infection where the epidermis separates from the underlying layers and you get desquamation of the skin. Influenza virus is another cause of atypical pneumonia. There are two viruses, influenza A or B, and when you get the flu shot every year, if you do, it's to try and prevent infection with this virus. There are a lot of non-specific symptoms to influenza infection: fever, headache, myalgia, malaise. In addition, the respiratory symptoms that people get are a non-productive cough and a sore throat and a runny nose. And the major complication of influenza virus that you should know about is a secondary bacterial pneumonia. So as people are recovering from influenza virus, they're vulnerable to a secondary infection with a bacteria that can be life-threatening. Bacteria that like to do this are Strep pneumoniae and Staph aureus and H. flu. And the classic history of this is a patient who's recovering and then gets worsening symptoms after they had an initial improvement. And this is the reason that people die when there are influenza virus outbreaks. It's not the virus, it's the secondary bacterial infections that people develop. Cytomegalovirus is a very rare cause of pneumonia. It causes pneumonia in transplant patients on immunosuppressive drugs. And the one thing to know about cytomegalovirus is the owl eye intranuclear inclusions. This is an example of it down here. So the dark stuff inside this cell here is cytomegalovirus material, and there's a little clearing around it which gives it sort of a halo, and this is described as an owl eye intranuclear inclusion. And that's what you see in tissue samples of patients who have CMV pneumonia. Respiratory syncytial virus is called RSV, and this is an infection that occurs in infants and children. The outbreaks are usually seasonal, so they happen in the winter months between November and April. If you do an inpatient pediatric rotation in the winter months, you will see many children hospitalized with RSV infection. It's the most common cause of lower respiratory tract illness in children. It causes a couple of different problems. It can cause bronchiolitis, which is inflammation of the bronchioles. It can cause pneumonia, and it can cause acute respiratory failure. It often starts as an upper airway infection, so the child will have a runny nose, and then a few days later they start to get lower tract symptoms, especially wheezing, because like I said, it often affects the bronchioles, and this causes narrowing and leads to wheezing. There are two treatments for RSV that you should know about. The first one is a drug called ribavirin. This is a drug that inhibits synthesis of guanine nucleotides so that the virus can't replicate itself. The second drug is used for prevention. This is a drug called palivizumab. This is a monoclonal antibody against something called the F protein. RSV contains this surface F protein, and the F stands for fusion because it causes respiratory epithelial cells to fuse. That's one of its pathogenic mechanisms. And this is sometimes used in preterm infants who are at very high risk for RSV, sometimes also given to children with congenital heart disease who could have a life-threatening infection if they get RSV. So the classic case to recognize for your boards is a young child, usually under 2 years old, who has fever and a runny nose, and then a few days later gets cough and wheezing. This may be a case of RSV. Next, let's talk about aspiration pneumonia. So this occurs when patients aspirate microorganisms, usually from the oral cavity or the naropharynx, into the lungs. So what type of patients would aspirate oropharyngeal contents into the lungs? Well, patients who have reduced consciousness, for example, if they've undergone anesthesia, they can't protect their airway and they can aspirate. Patients who have seizures can aspirate into their lungs. Alcoholics can lose consciousness and aspirate into their lungs. And then finally, people with dysphagia for any reason. So this commonly occurs in very elderly, frail patients, but it can also occur in people with ALS or myasthenia gravis who have neuromuscular weakness. Classic aspiration patients are debilitated nursing home patients or alcoholic patients. They can aspirate contents into their lungs. So the bugs that tend to cause these aspiration pneumonias are Klebsiella and Staph aureus, and then lots of anaerobic bacteria. These normally are present in the oropharyngeal cavity, so when you aspirate, you sweep them into your lungs. These are bugs like Peptostreptococcus and Fusobacterium and Prevotella and bacterioids. And the first-line therapy for aspiration pneumonia is clindamycin because it covers all those anaerobic bacteria. Klebsiella pneumonia is a rare cause of lobar pneumonia. When people do get it, it's often from aspiration. It's a very serious pneumonia. It causes marked inflammation and necrosis in the lungs. And it classically causes a thick mucoid and blood-tinged sputum to be produced, which is described as currant jelly sputum. And don't confuse this with currant jelly stool, which is a description of the stool in patients who have intussusception of their bowels. Next, let's talk about lung abscesses. These are contained fluid-filled spaces in the lungs with an infection. And the way they're described in a question stem is as showing an air fluid level on imaging, usually chest X-ray or chest CT. What happens is you get a walled-off area of infection, and there will be fluid and pus drawn down to the bottom by gravity, and it will create this appearance of an air fluid level, which is this line I've drawn right here inside the cavity on imaging. Lung abscesses are usually a consequence of aspiration. Rarely they can be caused by bronchial obstruction from a cancer. The bugs that cause these are predominantly anaerobes, and that's why they come from aspiration. You aspirate those anaerobes in your mouth and oropharynx, bugs like Peptostreptococcus and Prevotella and bacterioids and Fusobacterium, and those lead to the formation of the abscess. Sometimes Staph aureus and Klebsiella are also involved. And the treatment for these is the same as treatment for aspiration pneumonia. It's clindamycin. However, if the abscess is big enough, sometimes it has to be surgically drained. The final cause of pneumonia I'm going to discuss is Pneumocystis jirovecii, which used to go by a different name whose initials were PCP, and it's still often called PCP pneumonia. This is a diffuse interstitial pneumonia that requires immune compromise, classically HIV. This is considered an AIDS-defining illness. So a little bit of history here. When AIDS first developed in the 1980s, healthy homosexual men began to present to their clinicians with PCP pneumonia, which had previously bbeen very rare, and tumors called Kaposi sarcoma, which also were very rare. And as people began to work up the reason why these healthy young men were developing these rare conditions, that led to the discovery of the AIDS virus. PCP is a yeast which gets inhaled, and it usually causes no symptoms whatsoever if your immune system's intact. But if you have HIV and AIDS, you can get pneumonia from this bug. The way you diagnose PCP pneumonia is by looking for the yeast under the microscope. You either need to take a sputum sample or a bronchoalveolar lavage sample, and you can't culture this, so you have to stain it, and there are special stains required, and they all use silver. And what you see when you look under the microscope is something like this picture down here. Just remember this picture because this is a classic example of PCP, and the silver stain makes all the PCP bugs look dark black, like all these little circles that you see in here. These are the cysts from pneumocystis, and this is what it looks like under the microscope. The first-line therapy for PCP pneumonia is trimethoprim sulfamethoxazole, or TMP-SMX. It goes by the name Bactrim. There are also some second-line agents that are sometimes used, like dapsone and pentamidine. And we do often prophylax people so that they won't develop PCP pneumonia. Bactrim is given to HIV patients when their CD4 count falls below 200. And Bactrim is also sometimes given to patients who are on high-dose steroids or other immunosuppressive agents so that they won't develop a PCP infection. And that concludes our module on pneumonia.